confronted with clinical case scenarios of our patients, and we are always have problems coming to a diagnosis in our patients. From the history and the clinical signs, we are supposed to come to a reasonable diagnosis from where we can start further treatment for the patient. As medical students, clinical case scenarios are very important exam questions for them, especially the final MBBS exams. Therefore, it is very important for students to understand how to go about solving this puzzle of clinical case scenario in our patients or in our clinical cases that are given for the exams. I shall try to simplify the way how you can solve this clinical case scenario puzzle and come to a reasonable or working diagnosis for our patients so that the treatment can continue smoothly and effectively. The first thing that we come across is the history of the patient. Okay, history consists of a chief complaint or more chief complaints, and from there you list, once you have the chief complaint, you list the possible causes of this chief complaint that the patient may be having. After the chief complaint, we come to history of present illness, HOPI, and here we look at the issues or the pointers from the history of present illness and listing out the positive and negative symptoms. What further info you may need from the patient which is not listed in the case scenario. List the possible causes or diagnoses that you may derive from the history. Next, we come to examination. In this examination, you analyze the signs that you obtain from the patients. So, you look for the issues or pointers from the physical signs, issues or pointers from the examination and elicitation of signs. You class them as positive and negative signs. Then, what further signs you would like to look for in the patient further? And then, what diagnosis can you exclude from the history after the physical examination? Okay, once you analyze these symptoms and the signs, then you come and make a diagnosis. First, you have to come to a provisional diagnosis, which is the most likely diagnosis in this patient. And it must be based on the symptoms and signs that were given or you find on the patients. And this diagnosis that you consider must be common and relevant to the particular case scenario or to the patient. Secondly, you have a number of at least 3 other possible diagnoses, which we call differential diagnosis. After the physical examination and the history before that, we have come to a certain provisional and differential diagnosis. And next, we decide what investigations you want to order for these patients to confirm the diagnosis that you have decided. So the investigations can be classed into A, routine or baseline investigations, usually of the blood and urine. The second is diagnostic, blood tests or urine tests that can clinch the diagnosis in certain patients. For example, amylase for acute pancreatitis and troponin T for myocardial infarction, and some serum markers for the various cancers that we have. Next is plain X-ray of the plain X-rays. Okay, these are very commonly used, but often provide some useful information which can lead you to decide what further investigations you want to do. Next is ultrasonography or ultrasound scan, which is also a very important and useful initial examination, as it is very convenient, easily available, and also cost effective. Following that, you come to the CT scan, computer tomographic scan, okay, which are more expensive, and this could be done only when in special cases which are indicated after your clinical examination and after doing the basic investigations. Subsequently, you can go on to do MRI and MRCP in surgery. And the other important examination is ERCP. This is for jaundice patient, especially obstructive jaundice. Another commonly used investigation is endoscopy, upper and lower GI endoscopy, okay, OGDS and colonoscopy. Following this, we do special tests, sometimes like CT angiograms, venograms, or radioisotope scans. These are the special tests which will not be done routinely for every patient when this is decided by what you get on the results of your earlier investigations. And finally is the biopsy, which is a tissue diagnosis which confirms the diagnosis. And this biopsy can be a FNEC, true cut or core biopsy, excision, incision biopsy. So all these will confirm with the tissue diagnosis of what the patient is suffering from. And finally, based on your clinical investigations, clinical findings, your investigations, sometimes special investigations, you come to rule out a number of causes, and finally it should give you the final diagnosis of the patient. And subsequently, with the final diagnosis or definitive diagnosis, you should be able to carry on the treatment, which can be medical and pharmacological or surgery. Surgery again can be endoscopic, minimally invasive, or open invasive surgery. Okay, so you must understand that as far as possible, we try to do as minimal as possible. Endoscopy, minimally, and finally is the last open surgery. And the final part of the treatment is your long-term management of the patient and at times rehabilitation of the patient. After going through this analysis of the case scenario at hand, as a medical student, it's very important for you to decide what was your learning objective and what were you expected to learn from this case. And secondly, did you achieve your intended target? And thirdly, what more have you got to do to improve your knowledge regarding the case that you have encountered? Go through a case scenario to illustrate how it can be analyzed simply. The patient is a 19-year-old man who presents with a 2-day history of abdominal pain. In the history of present illness, the pain started in the central abdomen and has now become constant and has shifted to the right iliac fossa. The patient has vomited twice today and is off his food. His motions were loose today, but there was no associated rectal bleeding. On examination, the patient had a temperature of 37.8 degrees Celsius and a pulse rate of 110 per minute. On examination of his abdomen, he had localized tenderness and guarding in the right ilia fossa. Urine analysis is clear. These were the results of the investigations done on the patient. Now, let's analyze the case scenario. Okay, first come to chief complaint. The chief complaint of this 19-year-old man is a 2-day history of abdominal pain. Now, let's consider the possible common causes of acute abdominal pain in a 19-year-old man. And these are some of the common diagnoses that come to our mind. Acute appendicitis, acute gastritis, acute gastroenteritis, right ureteric colic, acute pancreatitis, acute cholecystitis, and peptic ulcer. In the present history of present illness, we are given more information about the pain. The pain started in the center of the abdomen and radiated to the right ilia fossa. The patient vomited twice and is off his food. His motions were loose, but there was no associated rectal bleeding. Okay, what are the pointers for the issues that can be obtained from this history and history of present illness? We have the positive symptoms and the negative symptoms, relevant negative symptoms. Positive symptoms, abdominal pain. Okay, of 2 days duration, associated with vomiting. Pain radiates from the center abdominal region to the right ilia fossa. Pain was associated with loss of weight and loose motions. And under the negative symptoms, there was no rectal bleeding. And the further information that is needed from this patient is the nature of whether he had fever, whether there was vomiting contents. What were the contents of his vomiting? Was it blood? Was it coffee ground? And urinary symptoms. Were there any urinary symptoms? Hematuria, dysuria. Okay, these are the common issues or pointers that we can gain from the history. So from the history, chief complaint and the history, we can come to the few possible diagnoses. Acute appendicitis, acute pancreatitis, acute cholecystitis. And by exclusion, we can exclude acute gastroenteritis, right ureteric colic, and acute gastritis. Now we come to the physical examination. The patient has a temperature of 37.8 degrees Celsius and a pulse rate of 110 per minute. On examination of his abdomen, he has localized tenderness and guarding in the right ilia fossa, and urine analysis is clear. Again, we summarize his physical findings or physical signs under these 3 categories. First, the positive signs. He is febrile with a temperature of 37.8, tachycardia 110 per minute, and there's localized tenderness and guarding in the right ilia fossa. So these were the positive signs that you get from the physical examination. The negative signs that you see in this patient are no epigastric tenderness or guarding, no lumbar tenderness, and the urine analysis was normal. Okay, these 3 are the negative signs which were not present in this patient, and that will exclude some of the other causes. And you want to know further, you want to know whether he had jaundice, whether he had pallor, and his hydration status, which were not mentioned in the history. Okay, so after the physical examination, we have come to the provisional diagnosis of acute appendicitis with the differential diagnosis of acute gastroenteritis and acute pancreatitis. Then go into the investigations. It is notable in these results of investigation, the white cell count is raised, suggesting some form of infection. The C-reactive protein also increased, which also suggests some acute inflammatory phase. So these together comes under here. These are the pointers: leukocytosis and C-reactive protein, which suggests something infection or some inflammatory process that is going on. And the required or expected test, serum amylase, which is we assume must be normal. Urine analysis we are told is normal, and we would like to do an ultrasound of the abdomen and pelvis, which presumably is normal. If these are required tests are normal, and then with leukocytosis and C-reactive protein raised, will suggest as an inflammatory or infective cause as the cause of disease. And among the three, you will have the final diagnosis will be acute appendicitis. In summary, these are the 9 steps to a diagnosis. First, get a reliable chief complaint and consider the common possible causes of the chief complaint. Then, in the history of present illness, get the detailed history in relation to the chief complaint of the patient. Thirdly, after with the chief complaint and the history of present illness, list the positive symptoms and the relevant negative symptoms. And subsequently, from these, list the possible diagnosis from the history. Then you go to the second part, the 5th step, examine the patient thoroughly. List the positive and relevant negative signs or findings in the examination. Then you name 1 provisional and 3 differential diagnoses, which must be common ones. Next step, review the investigations that has been done or that you want to be done. And finally, consider all the findings from the history, physical findings, and the investigation, and by reasoning and by exclusion, determine the final diagnosis of the patient.